Now we're going to go over some additional nursing care for stroke patients and also patient education. Our objectives will be that you will be able to identify the heart rhythm that places people at risk for ischemic stroke, list 2 complications following a stroke that nursing care can prevent, and list the 5 required patient education topics for stroke centers. First off, we have is blood pressure management for ischemic strokes. And really, there is no proven optimal range of blood pressure in acute stroke. Our goal is to maintain perfusion to the ischemic area and the ischemic penumbra. We know that we want to avoid hypotension because hypotension is more detrimental than hypertension, and hypotension causes more deaths following a stroke. When we're treating hypertension, we treat it if it gets higher than a systolic blood pressure of greater than 220 millimeters of mercury, or if the diastolic blood pressure gets greater than 120 millimeters of mercury. We also want to treat it if we see any signs of end organ damage. And also if the patient is a candidate for alteplase and the systolic blood pressure is greater than 185 or the diastolic is greater than 110, we can treat those as well. With the blood pressure, we also want to remember that if the patient has an ischemic penumbra, is that we have what's called permissive hypertension in their stroke center. So with this, that salvageable brain tissue around the area of core infarction, we want to make sure we're treating it and treating it well by allowing permissive hypertension, and allows up to a systolic, and I apologize, it should say 220 as the highest systolic blood pressure. And we might also put patients in Trendelenburg positioning to keep blood flowing to the brain. As well, we want to, these patients may be assessment dependent, meaning that for patients that if they're sitting up, they actually have more deficits than if we lower the head of the bed. And that's why we might put them in Trendelenburg. As well, we want to be cautious with lowering patients' blood pressures after a stroke. And usually we might lower it just gradually by about 15% during the first 24 hours, and then gradually controlling the blood pressure within a few days to a week. We want to make sure we're maintaining blood pressure to the ischemic area, but we also don't want it to be too high or too low. For patients that have had a hemorrhagic stroke, these patients, we do want to do better blood pressure control. For ICH patients presenting with a systolic blood pressure between 150 and 220 millimeters of mercury, and without contraindication to acute blood pressure treatment, acute lowering of their blood pressure to 140 millimeters of mercury has been found to be safe and effective for improving functional outcomes for these patients. For ICH patients that present with a systolic blood pressure of greater than 220, they say it may be reasonable to consider aggressive blood pressure reduction with a continuous infusion and more frequent blood pressure monitoring. With cardiac monitoring with these patients, as I said, we get a 12-lead EKG and put these patients on cardiac monitoring for at least 24 to 48 hours. And we're monitoring them for atrial fibrillation. Atrial fibrillation is the most common dysrhythmia. And when a patient has atrial fibrillation, it's when there is a quivering or irregular heartbeat that can lead to blood clots, stroke, heart failure, and other heart-related complications. About 15 to 20% of people who have strokes have this heart arrhythmia. And this heart arrhythmia, since it increases the risk of forming clots, it's going to increase the risk of having a stroke. And there are about 35% of people with atrial fibrillation will actually suffer a stroke. So with these patients, most of them are on blood thinners, or they're started on blood thinners while they're in the hospital. And sometimes when they're in the hospital, we don't see any atrial fibrillation. So these patients actually might get discharged with a cardiac monitor, a portable one, so that we can, and do it for 30 days, to see if maybe they have paroxysmal atrial fibrillation. Even though untreated, atrial fibrillation actually doubles the risk of any heart-related deaths and is associated with a 5-fold increased risk of stroke. Many patients are unaware if they have atrial fibrillation until they actually get an EKG. Now looking at the management of complications and risk factors. First off is dealing with the patient's lungs and monitoring the respirations and pulse oximetry. We can see respiratory failure in up to 6% of patients that have an ischemic stroke, and much higher, up to 30% in patients that have a hemorrhagic stroke. We want to make sure we maintain adequate airway and oxygenation, and support them to prevent any hypoxia. We want to make sure that they get enough oxygen, as we know that hypoxia and increased CO2 are vasodilators, and we don't want to cause increased edema in the patient's brain. We also want to make sure we prevent aspiration pneumonia with all our aspiration precautions and keeping the head of bed at 30 degrees. These patients, because they're not moving around as much, they might have impaired sensation and mobility, they're going to be at increased risk of skin breakdown. So we do want to make sure we are turning and positioning the appropriate patients every 2 hours, that we order specialty low air loss overlaid beds to make sure they're on the best surface to prevent any skin injury. We want to make sure we're floating their heels. We want to do daily skin checks. We also want to make sure we're monitoring our patient's nutritional intake, as having poor nutrition can increase the risk of a patient getting both an infection, but also if they get a wound here, it's not going to heal as well if they have poor nutritional intake. We also we know our patients can have impaired physical mobility, and they might be impaired in doing their activities of daily living. So we like to promote mobility early. But it is good to also talk to patients about fatigue. Post-stroke fatigue is often seen after a stroke for both patients that have severe strokes and even patients that have less severe strokes. They'll be amazed at how fatigued they are. And so having rest periods throughout the day is important. As well, these patients are at risk for contractures, from having loss of movement in extremities. So you want to keep in mind that once you start feeling some more tone in those extremities, that you let occupational therapy be involved so we can get braces and whatnot to prevent contractures from happening. As well, with our patients that have a stroke, because they have weakness, they can have subluxation of their shoulder. So we make sure when we're turning these patients, we never pull them from their arms. We always use their shoulder and their hip and their body to turn them. As well, these patients can be deconditioned, and we want to do increased mobility, getting these patients out of bed to also help their respiratory status, and making sure that we get physical therapy and occupational therapy involved as appropriate. Patients after a stroke are at increased risk of falling. It is actually really common after a stroke. About 14 to 65% of stroke survivors may fall in the hospital, and up to 73% fall within the first 6 months of discharge. So it is something that here in the hospital, we want to make sure we're doing a fall risk assessment, and we want to provide them a fall risk education, both for in the hospital and at home. We also want to make sure that our units that are taking care of stroke patients have fall prevention programs in place so we can do our due diligence in preventing patients from falling. We want to make sure we prevent our patients from having a stroke from having an infection, right? We don't want to have their temperature get too high. So we want to make sure we're doing adequate hand hygiene. We want to maintain isolation standards as appropriate. And we want to remove any urinary catheters or invasive intravascular devices as soon as possible to prevent them from getting an infection. Here's a list of the 8 primary stroke center performance measures. STK on here stands for stroke, and these are best practices to improve the long-term outcomes for stroke patients. So let's go over these. Before we go over them, when we look at the outcomes we get for stroke patients, is that we do a lot of data collection, and we're collecting data of how well our patients do at 90 days after a stroke, whether they got TPA or not, whether they got a mechanical thrombectomy or intra-arterial TPA, because we want to know what are our patient outcomes after they had a stroke. And with that, we use this scale called the modified Rankin scale. And this measures functional independence and gait stability, and we use it to measure our stroke outcomes. It is a scale from 0 to 6, and you can see the scoring here to the right, with a 0 being no stroke symptoms, a 5 being severe, where the patient is bed-bound, incontinent, and requiring 24-hour care, and a 6 that they're not showing you there is that at 90 days the patient has died. Let's go back to the stroke measures. So the first one is VTE prophylaxis. We need to make sure we put sequential compression devices or SCDs on our patients to prevent VTEs. And we need to make sure we document that those are on our patients within the first 24 hours of the patient coming to the hospital, unless it's documented that it's inappropriate for those patients. Some hospitals still use compression stockings for patients. We stopped using compression stockings after a study that showed increased risk of skin breakdown. But if your patient is ordered for compression stockings, we do need to make sure they're on the patient and documented. We also need to have providers order the subcutaneous heparin or low molecular weight heparin for our patients as the pharmacological prevention of VTEs. We also need to make sure we're monitoring for signs and symptoms of DVTs and pulmonary embolisms. For the stroke measures number 2 and number 5, these are both dealing with antithrombotic treatments. STK2 is that all patients that have a stroke are discharged on an antithrombotic, and if they're not, there's documentation of why. And then STK5 is that antithrombotics are administered by end of hospital day 2. So with this, there are some differences, so that if a patient received IV alteplase with or without a thrombectomy, we make sure we don't start this till at least 24 hours after treatment. As well, some patients may be appropriate for dual antiplatelet therapy, and we want to keep that in mind. Also, sometimes we have had it that we've missed this because your patient loses enteral access and you can't give them the pills for aspirin. And so something we try to remember is that aspirin also comes in suppositories. So if we can't get it into either an enteral tube or they're not able to swallow, is that we can give them a suppository to make sure we still give it by the end of hospital day 2. STK number 3 is that for patients that have atrial fibrillation, they are started and treated with anticoagulation. And if it's not appropriate for them to be anticoagulated, there is documentation by the provider as to why. STK4 is thrombotic therapy, so that all patients that show up to the hospital that are eligible for TPA should receive TPA. STK number 6 is that all patients are discharged on a statin. Examples would be atorvastatin, rosuvastatin, simvastatin, and these are all used to lower cholesterol levels and have been told to decrease and improve outcomes for stroke patients and decrease the risk of having another stroke or a heart attack or death from heart disease by 25 to 35%. A big one that we focus on with nursing is the STK8, the patient and family education. And we base this on the American Stroke Association's Get With the Guidelines Stroke. These are the 5 mandatory educational topics we have to go over with the patients. First one is for how they activate the emergency medical system once they're discharged. We like to not only talk about this while the patient's in the hospital, but we also talk about it especially on discharge. So we want to make sure this verbiage is also in the discharge paperwork. Also in the discharge paperwork, and what we need to talk to them about is that there needs to be follow-up after discharge. It's not like someone has a stroke and they should never see a doctor again. We want to make sure that the patient's risk factors remain as controlled as possible once the patient is discharged from the hospital. The third thing we have to educate them on is any of their medications that are prescribed at discharge. And so we want to make sure that throughout their stay, anytime we're giving them new medications, we document that we've given them education about those medications. And these will be medications for blood pressure management, cholesterol, the antiplatelet medications, the anticoagulants. We want to make sure we give them education on those. We also need to give them education on their own risk factors for stroke. And this is something that when we document that we've given them education on risk factors for stroke, we need to individualize this education so that we're documenting that we've gone over the patient's specific risk factors for stroke. I still, if there's family in the room, will go over all the risk factors because I want to let the family also know so they can be aware of their own risk factors for a stroke. The 5th education topic we have to give patients is the warning signs and symptoms of a stroke. And you want to make sure you're repetitive with this. As I said, fatigue and sometimes patients' memories can be not as good when a patient's in a hospital, and especially following a stroke. So you want to make sure education is started early and it is repetitive. Here at the bottom, I have a link to a website, and this is where we get all of our handouts that we give to our patients for all 5 of these topics, but including additional topics from the American Stroke Association. STK 10 is our last measure, and this is that all patients are assessed for rehabilitation needs. And for us, we use the AMPAC mobility and activity scores to help us decide whether a patient is appropriate for physical therapy and occupational therapy, and we do the swallow screen to see if the patient's appropriate for speech-language pathology. We want to make sure as nurses, if we see a patient, we see any need for physical or occupational therapy or speech, that we bring that to the provider's attention. And if we find that the patient is intact and doesn't need any of these therapies, the providers need to document that they were assessed for their needs and the need for those therapies were not needed. But otherwise, we do want to make sure these therapies are involved with our patient care. Thank you so much for listening to my presentations here. If you have any additional questions, you can contact me here, and I gave you my email address. Thanks.